So good morning, and thanks everybody for joining us for Grand Rounds this morning. And a special thanks to Dr. Freyer for coming so early from California for this call. So on behalf of the LURIE Cancer Center and the Adolescent and Young Adult Cancer Program, it's my pleasure to introduce our speaker today, Dr. David Freyer. He is a professor of clinical pediatrics, medicine, and preventive medicine at the University of Southern California, and also the Keck School of Medicine specifically. He currently serves as director of the Survivorship and Supportive Care Program at the Cancer and Blood Disease Institute at Children's Hospital Los Angeles. He is also the director of the Cancer Survivorship Program and co-director of the Adolescent and Young Adult Cancer Program at the USC Norris Comprehensive Cancer Center. Dr. Freyer is also founding co-director of the USC Center for Young Adult Cancer Survivorship Research. And he's the immediate past chair of the COG AYA Oncology Discipline Committee, which he led from 2009 to 2019. So appropriately, he'll be presenting on cancer in adolescents and young adults, progress and challenges. And as Kate mentioned in the chat, please enter any questions for Dr. Freyer via the Zoom chat, and we will address them at the end of the presentation. So without further ado, I will turn it over to you.
Great, thank you, Stacy. I'm going to just stop my video here, and I'll thank you very much, Stacy, for the introduction, and I'd like to thank you and others and Dr. Moreira for the invitation to present today. It's really an honor, and I will say that I'm a native Chicagoan, and it's always enjoyable to be back in the 312 area code. Although I will say that the 312 area code when I lived there was much larger than than what it is now. I think it's downtown Chicago. They've narrowed it, but anyway, it's a great pleasure, and I wish we could be with each other in person, but not today under the circumstances. For disclosures, I don't really have anything to present with respect to this lecture, although, yes, is that any better? Hopefully that's better. I don't have any disclosures really related to this presentation other than, I guess, the fact that it's 6 a.m. here and I'm still on my first cup of coffee, and 9 months into the pandemic, you'd think we'd have all the technical glitches worked out, but that isn't always the case, and hopefully everything will go smoothly with this. Please do interrupt me if there's anything that I can fix about the presentation, the audio-visual component of it, to make it clearer. So it's always hard to decide what to cover in a 1-hour lecture on a topic that's vast. And I sort of weighed going deep on something narrow in this discussion of AYA oncology or versus going wide and touching on a few different areas. I decided to do the latter. So over the next 45 minutes or so, what I'd like to do is sort of hit a few high points in 5 different areas that I think are crucial for AYA oncology and sort of exemplify, I think, many of the challenges. And those areas are survival, biology, toxicity, clinical trial enrollment, and then one of my favorite areas, survivorship. And I'll sort of summarize the recent progress and future directions in all of those areas, at least as I see them from my perspective, and then finish up with maybe a few thoughts about research priorities and opportunities that we can all pursue. So beginning with the recent progress and future directions, I'd like to start with just knowing where we came from. And I think this, for anybody working in AYA, this is an important slide. This is just the cover of the Adolescent Young Adult Oncology Progress Review Group report called A Call to Action that was published in 2006. It was a project, a collaboration between the NCI and then Livestrong Young Adult Alliance. And what this landmark document established were a couple of things. One, very pragmatically, it defined adolescent and young adult oncology as 15 to 39 years of age, a figure that we're all familiar with. But then it also developed 5 different high-level recommendations in the executive summary. I won't go even over all those here, but as you can see, what they deal with is defining the uniqueness of the cancer burden in AYA, awareness, prevention, access, quality of care. What are the tools needed for research in this discipline, the delivery of healthcare services, and then advocacy and support. These 5 areas really do cover most of the important charges, if you will, that came from this important document. And some of them I hope you'll recognize as being addressed in some of the research that I cover here. So first of all, summarizing where we are in survival. Again, starting at the beginning, this slide here came from the AYA Progress Review Group that I just mentioned, a very important and probably very recognizable image that many of you have seen many, many times. And this is the display of showing the improvement in 5-year relative survival for invasive cancer in AYAs, comparing that to younger children and older children. And without belaboring this point, you can see that in the center of this graph is a deep V, which was the survival improvement for the adolescent and young adult age group. And as you can clearly see, over the 1975 to 1997 timeframe, it was lower than either of the other groups. And this certainly was alarming, and probably more than any other single observation, I think, propelled the development of the AYA movement, if you will. We decided at USC, my wonderful research colleagues and I at the USC Department of Preventive Medicine and the Cancer Surveillance Program, the Los Angeles County Cancer Surveillance Program, which is part of the SEER regimen, led by one of my colleagues, Li-Hua Liu, felt that since the data set on that slide that I just showed ended in 1997, that we were ripe for an opportunity to relook at those data. So we went back to to update cancer survival in AYAs by using the then most recent SEER data release, and we adjusted it for the impact of something we thought might be important in interpreting the data, which was the HIV/AIDS epidemic. So we looked at SEER 9 registry data, looked at 5-year relative survival for the AYAs, and compared them to younger and older patients for the diagnosis period of 1973 up to 2009. We included all invasive cancers and did not exclude any. And then we looked at it with and without the influence of Kaposi sarcoma and lymphomas. And as you can see, the numbers were over 3.2 million patients. What this slide shows is the 5-year relative survival map of AYAs and younger and older patients mapped out over the time period 1973 to 2014. On the left are males and on the right are females. Children are in green in both figures. AYAs are in red, and then older adults 40 and up are in blue. And what you can clearly see is that for younger patients and older and AYAs, survival was on pace pretty much with all groups from in the earliest years of this time frame. During the middle period of the time frame, not much change seen on the female side, but in the male side, or in the AYAs on the male side, you can see a notable dip. And then in the last roughly quarter or so of the time frame, you can see that they recovered, and they're all about the same pace of improvement. When we broke that out and looked at AYAs only, again, males on the left and females on the right, you can see on the right in the females that among the AYAs, youngest patients in light pink, oldest patients in dark red, you can see that there really wasn't much change over that time frame. But in contrast on the left, you can see that again, in that dip in the middle of that time frame, affecting the males. And at the top are all cancers included, and then at the bottom are excluding Kaposi sarcoma and lymphoma. So it's very interesting that when you exclude these two HIV-associated groups of cancers, that dip really sort of disappears. And I think in retrospect, we can say that was a significant part of that low survival improvement that we had noted for the AYA age group. So in some ways, this is good news. It certainly was a testament to the effectiveness of antiretroviral therapy and its deployment on a wide scale. So this, I think, puts AYA survival into perspective to some extent. This is a recent publication that comes out every couple of years from the SEER registry. This is, some of you have probably seen this. This was just published in CA, Cancer Journal for Clinicians, by Miller and colleagues. And what it shows, using the same data set, but a little bit, even more recent, is that in the upper panel, AYAs 15 to 19 years, the middle panel 20 to 29, and then the right-hand panel 30 to 39 years of age. You can see that the top graph is cancer incidence, and actually cancer incidence has been continuing to increase in the AYA age group. You can see this bump in the 20 to 29-year-olds and 30 to 39-year-old males, again corresponding to that rise in AIDS-associated or HIV-associated malignancies. But you can see down on the bottom that cancer mortality has been steadily decreasing over that time. This doesn't capture that dip due to the HIV-associated cancers, because all of this is capturing cancer-specific mortality, is capturing only deaths due to cancer and not other conditions like HIV itself. But you can see a steady drop. So I think that the data are very consistent. And then interestingly, the table at the bottom are some examples of 5-year survival. Just to pick out a few from this paper, comparing younger AYAs to older AYAs and middle AYAs, you can see that for all cancers, 5-year survival is I think that it actually averages out to be 84.7% across the age groups. But again, 5-year survival is quite good in the AYA population as a whole. Although, as we're going to see in just a few slides, there are some pockets of poor survival that now need to be more of our attention. Some cancers, like testicular cancer, uniformly good outcomes across this age group. The next two, ALL and brain, you can see some difference between the younger patients doing quite a bit better than the oldest AYA patients. And then in bone, you have a little bit of a reversal of that, where the youngest patients, the 5-year survival is not quite as good as it is in the older patients. That probably reflects differences in histology. So, as I said, there are persisting AYA survival deficits, and I cherry-picked a couple of examples to sort of make this point. On the left, talking about survival disparities, if you will, within cancer types. This is osteosarcoma patients. These patients came from a series of COG studies of osteosarcoma, and in aggregate, what the figure shows, this Kaplan-Meier plot, is that the youngest patients have the best survival. The patients 18 years and older have the poorest survival, and there's a statistically significant difference in the hazard ratios here, with less good survival for the older age group. This isn't clearly understood yet, but it's certainly, these are data that have held up. And then survival differences by treatment approach. And if you will, this graph here that shows, again, COG data for outcomes for acute myeloid leukemia, comparing pediatric regimens with what were then being used, or actually even before that time, since this was retrospective, in the adult sort of setting. So these were all 16 to 21-year-old patients who were diagnosed with AML, and in concurrent timeframes. This is not a randomized study, but just concurrent timeframes. You can see that the patients who were treated with COG on COG trials did have a statistically significant higher overall survival than those who had been treated on the adult regimens from CALGB and SWOG concurrently. Now, therapy is getting better for everybody, and this needs to be looked at again, but at least at that time frame, historically, it did show that there are still some survival deficits within the AYA age group. This next slide shows the influence of stage and a number of socio-demographic characteristics that impact on overall survival of the AYA age group. And this comes from a project from our Los Angeles County Cancer Surveillance Program, again, part of one of the original 9 components of the SEER program. This is chiefly Southern California and Los Angeles County and beyond. What this analysis looked at were 71,225 AYA patients, 15 to 39 years of age, who were diagnosed between 2008 and 2014. And what we were trying to do with this was really just to try to get a good look at what was happening with survival with this AYA group, using the very rich, culturally diverse population of Los Angeles County, where we could try to get some sense of what the impact might be of some of these other variables. So I just, again, picked out a few examples here. In the upper left is the influence of sex. This is brain tumors, and something that's been seen repeatedly in many analyses is that males just don't do as well as females do across many cancers. This is shown for brain tumor here. And all of these differences, by the way, are statistically significant, although I don't show the p-values on the log rank test. In the middle upper is the influence of age. This is Hodgkin lymphoma, just to pick out. In this case, the lowest curve are the 35 to 39-year-olds. The best curve are the youngest AYAs. So you can see it sort of layers out by age group. In the upper right, the influence of race, ethnicity. This snapshot is from bone and soft tissue sarcoma. Sadly, a finding that we have seen over and over again across almost every cancer is the poorer outcome of our Black brothers and sisters who are diagnosed with cancer. The best outcome is usually non-Latino whites, and Asian and Latino whites usually fall somewhere in between. But again, we've seen this time and again. Socioeconomic status in the lower left. This is breast cancer here. Low SES has a poorer outcome than highest group of SES by quintiles. And then on the lower right is the influence of stage. This is an example from colorectal, with the curve at the bottom sadly showing a very poor outcome with patients who have metastatic colorectal carcinoma, and considerably better outcomes if it is non-metastatic. Again, this is a pattern that we've seen across many cancers, and that's displayed here in this slide. I won't go over each one individually, but you can see that in cancer after cancer, cervix, melanoma, bone, kidney, stomach, etc., that if you have metastatic disease, the outcome is likely to be much, much poorer. When we actually quantitate this and calculate adjusted hazard ratios for all of the cancers that we analyzed in aggregate, the risk of dying was 6.32, greater than if localized disease were present. But the range of hazard ratios was really astonishing. It ranged from 7.19 of the others to 33.9 for cervix cancer, stomach. They were, believe it or not, the hazard ratio of dying was over 30. So I think the way that we interpret this is that metastatic disease is maybe in some ways kind of the holy grail for being able to further improve AYA survival, and indeed probably survival in all age groups. In the same analysis, we looked at temporal trends of survival. I picked out 3 examples here of where between 1988 to 2000, that time frame, and then compared that to the time frame 2001 to 2014. Did we see any improvement? And it depends a little bit on which cancer you look at. Most of them, it did show improvement, which is certainly what we would hope. On the left is probably the most dramatic example of that, which is chronic myeloid leukemia, where with the introduction of tyrosine kinase inhibitors, survival dramatically improved. Most of us who take care of that condition are well aware of that. In the middle is ovarian carcinoma, which showed no change over that time frame. And sadly, for bone and soft tissue sarcoma in the right panel, 5-year survival actually worsened, and particularly in Black patients. And so this needs more investigation to explain it, but as you can see, there's a variety of outcomes here. So I think in terms of future direction with survival, I think we are over the hump and kind of don't need to think about AYA patients as uniformly poorer outcome with cancer. I think there are many studies now showing that that just is not the case. But it doesn't mean that everybody is home free by any means. We need a more nuanced approach and focus on pockets of poor survival, is what I like to call them. So these are poor prognosis histologies, advanced stage in certain cancers, and then as we've seen, racial and ethnic and other socio-demographic group disparities. Plenty of work to do there. The next area I'd like to look at is biology. And this is a wonderful review article published just a couple of years ago by Jim Tricoli and Archie Blyer, summarizing some of the confirmed or suspected biology differences in the cancers themselves for ALL, breast cancer, colorectal cancer, melanoma, and sarcoma, all cancers that are suspected or confirmed to have age-associated differences. The one example that I showed here on the right is receptor status, hormone receptor status in breast cancer by age. I think, as you can see in the boxed area on the left, that there are differences in patients with HER2 expression, ER, estrogen, and progestin receptor positivity. And I think particularly at the bottom, something worth noting is the so-called triple negative, where it's HER2, ER2, HER2, ER, and PR negative. This histology is more common in the AYA age group, particularly among Black women. It has a more aggressive course as a whole with a poorer outcome. And so it's a good example, I think, of a biology difference in older AYA patients. One that I'd like to highlight, which I think is a success story and shows the value of trying to understand cancer biology a little bit better on an age-specific basis, is the wonderful story of acute lymphoblastic leukemia and how treatment has improved for that over the recent years. So the panel that is shown there now, hopefully you can see it okay, but the point of this is simply to show that for these are event-free and overall survival of a large cohort of patients from several different registries that shows what we all know, which is that the youngest children with ALL have the best long-term survival, both event-free and overall survival, whereas adolescents and then particularly the young adults had much poorer survival. This disparity was well known. And then along came PH-like ALL, and this landmark publication in 2014 that I'm sure many, if not all, are familiar with. What this shows is the influence of the BCR-ABL phenotype and then what came to be called the PH-like phenotype. And I just draw your attention to what I just highlighted in red, which is that in the adolescent and young adult age group, you can clearly see that the BCR-ABL phenotype and then also the JAK2 inhibitor and CRLF2 PH-like phenotype is much more common in the adolescent and young adult age group, such that when you look at the young adults 21 to 39 years of age, between those two phenotypes alone, almost 50% of the patients are accounted for. And you're all very familiar with the fact that the outcomes are not as good historically in those phenotypes, and they do require different therapy. So these outcomes here show the differences in survival if you have either the ABL class or JAK class alteration, which shows a worse outcome than if there are no fusions at all. So the really interesting part of this, I think, is how this information is now driving therapy. So this is the top of the schema for a study that everybody here is probably familiar with, AALL1732. This is an open clinical trial, a phase 3 randomized trial of inotuzumab for newly diagnosed high-risk ALL. And the point that I wanted to make here is that when these patients are enrolled and they go through induction therapy, they're in induction therapy, the molecular typing comes back on these patients, and there's a pathway for each of these different mutation classes. On the left, you can see that those who are identified to have pH positivity or pH positive ALL, and then on the right-hand panel are those with the pH-like type phenotype. And in both cases, there are treatment options for them defined within the COG menu of therapies. So for pH positive, they're transferred to AAL-1631, where they're treated with dasatinib, a tyrosine kinase inhibitor, active in this disease. And then in the pH light group, we even have therapy for that now using ruxolitinib on AAL-1521. So it's very exciting, I think, to see how the biology can, in fact, be integrated to improve therapy. Just to mention that there's an exploratory aim on this study too, which is interesting and pertinent for AYAs, which is a randomized intervention to improve adherence to 6MP. Some really nice work done by Smita Bhatia and colleagues using a phone-based app to notify patients and remind them to take their 6MP on time. So something very important that that we all know from clinical practice and have been documented in studies, that adherence is not as good to ongoing daily 6MP in adolescents and young adults compared with younger children who are more supervised by their parents. I wanted to just throw this slide in to say that biology does encompass more than the disease. AYA host biology is also a very interesting area. This table here just summarizes the status of pharmacology of chemotherapy agents across the age range. And as you can see, that for several chemotherapy agents here listed on the left, there are differences in the drug disposition status in younger patients, AYAs, compared with AYAs. And this is important because this could certainly influence how therapy is tolerated, both in terms of the disease efficacy, but also the toleration by the host and toxicity. So both cancer biology and host biology are ripe areas for research in AYA. So my thoughts about future directions in this arena are, we need further study of differences in cancer-specific biology. This may explain a lot of the differences that we do see by age. Biological determinants of metastatic disease clearly is important. A very interesting area, which is cancer epigenetics, or the influence of environmental exposures on host and how those exposures can change the cancer biology of the host, or the biology of the host, and possibly the type of cancers that they acquire, and then differences in host biology in regards to tolerance of and disposition of drug therapy. Switching now, probably a good segue into the next area, which is toxicity. I think for individuals who are clinicians taking care of AYAs, most of us know that these patients do experience different kinds of toxicity. In many cases, it's excess toxicity compared with younger patients, at least. That's where most of the comparisons have been done. And in a couple of cases, maybe not as much toxicity, which is interesting. Some examples where there are data that show this quite clearly of excess toxicity are listed here on this slide. Vincristine-induced peripheral neuropathy. Most of us who administer vincristine are well aware of this. A little bit newer problem that has been characterized better as PEG asparaginase-induced hepatitis and pancreatitis. Osteonecrosis, well known to be a problem for AYA patients. Infertility, azospermia and oocyte depletion, and then the issue of second malignant neoplasms such as breast cancer. I wanted to share just some thoughts that I've developed over the years thinking about AYA toxicity. I sort of classify them as acute, persistent, or late onset problems. I think this is sort of makes the AYA host a little bit unique compared with some others. On the left are acute toxicities. I think of these as those that develop during the AYA window, and many of them, although not all, do resolve. Some examples are listed there. Persistent toxicity in the middle are those that develop during the AYA window and then frequently persist, so they in fact become late effects. Examples of that are listed. And then in the last panel are late onset toxicities. I think this is an interesting group where the exposure to whatever the offending agent is happens at a younger age, perhaps during young childhood even, but it doesn't become manifested until the AYA period. And of course, a classic case of this would be ovarian failure, where periods haven't begun yet until the teenage years. They wouldn't be expected, and then they never develop because of toxicity that occurred before, but it doesn't manifest until the AYA period. Some organ problems like cardiotoxicity are late onset after anthracycline therapy as a child, and again manifest during the AYA period. And then of course second cancers is another area, like breast cancer, for example, where it really doesn't become a problem until the AYA period. And I think for those of us who work in survivorship for young adult patients, we're familiar with these, but interestingly, when the patients are treated as children in the pediatric setting, some of these things don't necessarily make themselves apparent, of course, and sometimes are not always in the forethought or the first thoughts of clinicians when making therapy choices, but they're clearly important, even though we may not see them during the pediatric timeframe. This slide here just picks out three examples to share some data for three of these different areas that I mentioned. In the upper left is the cumulative incidence of vincristine neuropathy on rhabdomyosarcoma and Wilms tumor trials in the children's oncology group. As you can see, with increasing vincristine dose, not unexpectedly, the incidence, these are cumulative incidence curves, so they're curves that go up are ones that show greater incidence. You can see that for the 12 to 15 and 16 and older age group, the incidence is significantly higher than it is in younger patients. This is what we know clinically, and it bears out in data. In the lower left is treatment-related mortality. Those same COG trials that I mentioned earlier for survival, this was a series of COG trials where the outcomes for 15 to 21-year-olds were compared for younger patients. And it was very interesting to find, and somewhat sobering to find, that the mortality was actually twice in the 15 to 21-year-old what it was in the younger patients, mostly due to infections. And this prompted a lot of interest in developing better supportive care for this age group. And on the right are some panels showing osteonecrosis, again, the cumulative incidence of this in a recent paper from Scandinavia. And this shows that in the youngest patients, 1 to 9 years old at the top, the incidence is quite low. In the middle panel are the 10 to 18-year-olds, where, again, we're familiar that in females, something on the order of 20% of patients before modifications in dexamethasone were introduced show avascular necrosis. And then in the older age group, and I like this study because it included older AYAs where we don't really have a good handle on some of this, but you can see that the cumulative incidence is probably somewhere in between what it is for the youngest children and the teenagers. So there's something sort of uniquely susceptible about those teenagers during that period of puberty, perhaps, that puts them at risk for this problem. So future directions potentially in the area of toxicity is characterizing more completely the toxicity. I think there's some real opportunities, real needs here. There are some toxicities have been identified that I've shown here, but others we really don't have necessarily even an awareness of them if they're significantly worse, but maybe not quite as clinically obvious or prevalent. Cross-age comparisons of younger and older patients, and I think in particular it would be interesting to see the patterns of toxicity in the AYA patients compared with older adults. There's some opportunities there as well. Certainly understanding the mechanisms of these toxicities would be helpful to develop strategies for prevention and treatment. After all these years of knowing about osteosarcoma, it still isn't clear that we have an actionable mechanism for preventing that other than trying to limit dexamethasone exposure. The next area that I think is very important for AYA is clinical trial enrollment. another favorite area of ours in the children's oncology group, and something that that has been studied to some extent, although solutions for the problem are still lacking, I guess, like so many things. In this slide here, I've just summarized what, again, I think probably many have encountered in their own practice, their clinical research practice, is the low level of participation of AYAs in studies. Many studies have been published on this, but I would say that as summarized here, the enrollment estimates are for patients under 15 years of age. About half of the patients end up going on clinical trials. That's it's higher actually if you look at if you sort of winnow it down to diagnoses where there is an available trial and so forth. But if you just take all AYA or all young children, about 50% go on to clinical trials. For patients 15 to 21, it drops at least by half, probably more. And for patients who are over 21 years of age, fewer than 10% in study after study actually participate in clinical trials. It's looks much more like the older age population in that sense. We did a study of this at the Norris Comprehensive Cancer Center in Los Angeles, and looked using a very accurate form of case link methodology, where we could actually look patient by patient at several thousand patients over a long time frame. We found exactly these things, that for patients at the Children's Hospital who are less than 15, 22% of the patients went on clinical trials during that time. And then for those who were 15 to 39, it was 6% overall for the cancer center. And even among the 15 to 21 year olds at CHLA, right in the same institution, only about 15% went on. So we found what others have found as well. The implications of this, of course, are important. We know that this was likely to slow progress in improving cancer survival. If they're not going on studies, they can't benefit from them. There's reduced access to novel therapies. We can't accession the types and number of biospecimens that we need to do the cancer biology and host biology studies. And then, of course, the studies like supportive care, quality of life, and epidemiology studies have poor representation of the AYA population. So whatever we discover isn't generalizable to this group of patients. In terms of trying to understand this a little bit better, though, and what's going on, I wanted to share with you a couple of studies that were conducted at our site, led by Stephanie Thomas, who was our AYA fellow and then junior faculty before she moved on to Cleveland Clinic, where Stephanie is now. But this is some work that she led. This was a prospective cohort study where we enrolled patients over a 1-year period, 15 to 39 years of age, and compared them to children within the Children's Hospital. And then we studied their fate, if you will, in regard to clinical trial enrollment. So they would be diagnosed with their cancer. And what we did was we looked to see whether there was a clinical trial that existed for them at the time that they were diagnosed. Was there one available for that study, and would they have been eligible for it? Then for that same patient, we looked to see if that clinical trial was available within the institution, either at CHLA for the younger AYAs or over at the Adult Cancer Center for the older AYAs. And then finally, we looked at whether they were enrolled on the trial. And before I sort of go into what those showed, you can see that this sort of maps to a construct that that we've been thinking about with respect to clinical trial enrollment, that it's kind of a linear process, if you will. When the patient is diagnosed, if all of these points, does the trial exist nationally? Is it available locally? Has it been opened at the institution? In other words, is it presented to the patient, and is it accepted by the patient? Every one of those boxes needs to have a yes answer to that question in order for the patient to be enrolled. So there are many more factors working against a patient making it through that pathway than there are to keep them on track. So with that in mind, here's what we found. We found that that in terms of clinical trial existence nationally, it's the AYAs at CHLA, AYAs at Norris, and then pediatric patients were spot on. They were all actually about 55% of the patients, regardless of age group, had a clinical trial that existed nationally for the cancer that they were diagnosed with. Sadly, at the end, you can see on the right-hand side that AYAs at both sites, CHLA and Norris, ended up the same, a very low level of participation, somewhere around 10% compared to the children in blue, which was over 30%. But the difference, but there was quite a difference in the reason why they didn't go on the trials depending on site. In the pediatric site here, you can see that the trial was available, but just must not have either been presented or taken up by the patient. And whereas at the Norris Cancer Center on the bottom, the clinical trials weren't available. In other words, they hadn't been put through the IRB and opened at that institution. So that's where some of the struggle is. So what this study did was it showed, at least at that point in time at this site, we did not, there are differences in why AYAs may not be going on to clinical trials. So it's very important for us, again, to do more research to try to tease these factors out and then develop appropriate strategies. So that has been addressed and is the subject of a lot of attention in this systematic review recently published by Liz Ciambita at NIH. It looked at studies that have been published about this issue of barriers and facilitators for AYAs going on to clinical trials. Very interestingly, for the time period 1976 to 2019, this review found only 13 papers out of 332 that were screened that were suitable to deal with this question. So I guess that in of itself is a statement. I won't go over all of these, but just to say that if you do take a look at this paper, it does tease out what the literature addresses in regards to each of those stepwise paths that I mentioned, the different steps in the path from clinical trial, from patient diagnosis to clinical trial enrollment for AYAs. These are the barriers. Less known about facilitators, but some of the things that came out of the literature that was published were that some interventions that may be helpful are developing institutional AYA programs. There's some evidence, in other words, that those may be helpful. Providing support for physicians and providers in the way of research infrastructure, such as research coordinators, to help spread the load. And then support for patients is probably very important for this population. Good communication with the provider, providing tailored health information in a user-friendly format. So those are all areas, again, that are ripe for further research and improvements. So prospective cancer-specific studies of clinical trial availability and enrollment, those are two important different factors. Evaluation of site-level factors and impacts. Assessing clinical trial uptake. In other words, are the patients, hearing it? Are they receptive to it? Are we doing the best job that we can in presenting these studies? And then finally developing some innovative resources to support both patients and providers. The last area that I'll switch to is cancer survivorship in this age group, another area that is very interesting and has lots of opportunities. So first of all, just to be clear about who AYA survivors are, I think not to belabor the point, but I think it is important when you're reading the literature and trying to understand what a study is looking at. There are actually three different populations of what we could call AYA survivors. There are those who were treated as children, in other words, treated less than 15 years of age and have now grown into the AYA age group. There are survivors of adolescent cancer treated between 15 and 19 who have now grown into the young adult age group. And then there are survivors of young adult cancer, so those who are treated actually as adults. And it's important to sort of keep these clear because there are some very important implications for care models and research in this group. What this slide shows is the landscape, if you will, of long-term complications of therapy for that group of patients who are AYA survivors of childhood cancer. In other words, these patients, were treated as younger children. And as most of you know, if you work in cancer survivorship, this landscape has been mapped very, very well by multiple investigators using outstanding resources like the CCSS, the Childhood Cancer Survivor Study, and then more recently, the St. Jude Life cohort. And in the upper left, as you can see in this study, again, very familiar to almost everybody, I think, is that in the survivors, you can see in the blue line here that the cumulative incidence of late effects goes up and up and up with additional time, such that by the time a patient is 30 years of age, somewhere between probably about 25% or so of patients have a late effect. When you look at on the right, the St. Jude Life cohort, which sort of breaks it out a little differently, looks at the number of late effects per survivor of any late effect, and then grade 3 to 5. You can see that by age 30, on average, about 7 late effects per survivor. And by the time these patients are 30 years of age, in terms of severe late effects, somewhere between 2 and 3 severe or life-threatening late effects, clinically significant for sure. And so the burden of late effects is high, as we all know, in AYA survivors of childhood cancer. An additional problem that is getting these patients in for continued follow-up, and this is worthy of a conversation or presentation all unto itself, how to best care for these young adult survivors of childhood cancer. But what the phenomenon that we all know is that they simply stop coming back, in their 20s, by the time they're even in their mid-20s. And so we've got to have more effective ways of engaging with this population. What's much less well known is the landscape of health outcomes for survivors of AYA cancer. What I've shown here on the left is a study that was recently published by the CCSS in Lancet Oncology, which shows for early AYAs, so this would be patients treated at 15 to 21 years of age, what their outcomes are. As you can see, by the time these patients reached age 30, now these are not young children, so this is limited to patients treated when they were 15 to 21. The cumulative incidence of late effects is somewhere around 15 to 20% for severe late effects, and higher than that for any late effect. And similarly, as you'd expect with cancer mortality, it decreases, or the mortality increases, but survival does fall compared with the US population as these patients age. Cardiovascular disease and some other health outcomes are shown here. And I think what the status is of health outcomes for survivors of AYA cancer is that we just don't have these sort of broad studies like we do from the cohorts like CCSS or St. Jude Life. Those cohorts just don't exist, unfortunately. So what we have are outcomes that are published within either very specific outcomes within certain populations, or maybe outcomes within certain diseases. So what this top panel shows is the cumulative incidence of cardiovascular disease in several cancers. This cohort comes from the Kaiser Permanente group. And as you can see, without going into great detail here, that cardiovascular disease is in fact significantly more common among survivors of AYA cancer than it is in their non-cancer peers. And in the bottom graph, it shows on the basis of patient-reported surveys, the percentage of patients reporting adverse health outcomes after treatment for testicular cancer. And as you can see, tinnitus and hearing loss lead the pack, but there are many others that these would all be mostly attributable to cisplatin therapy. So somewhere between 30 and 40% of these patients long-term are having tinnitus. I wanted to show this study published recently because it's really a nice broad overview that gets a little bit at the sort of landscape approach that needs to be taken for AYA, I think survivors of AYA cancer. This is from the MD Anderson Cancer Center registry published by Mike Roth and colleagues. And this shows clearly that 5-year survivors of AYA cancer, that survival is significantly lower than it is for age-matched US population. no great surprise. But this is important because this is not just newly diagnosed patients. These are all 5-year survivors. As you can see in the lower panel, breaking it out by sex, there's that female superior survival compared with males, again showing up. Blacks doing a little bit less well than whites over the long haul, again seen before, and then a breakout by age where the younger AYA patients compared with the older AYA patients tend to have a little better long-term survival. Getting at the impact of treatment though, and that's really why I wanted to show this slide, is this very interesting panel in that paper, which showed the impact of radiation therapy over the long haul. So large cohort of patients followed over time. Group 1 on the top had chemotherapy, everything else that you treat cancer with, but not radiation, whereas that group, the lower group, had those things plus radiation therapy. So you can see here that you get out to 30, well, somewhere beyond perhaps 20 years or so of follow-up, and radiation therapy probably does begin to have some impact on health outcomes, such that it's actually causing mortality. And then in terms of mortality, this paper was recently published by Chelsea Anderson and her group at the American Cancer Society and UNC. This shows cumulative mortality among 5-year survivors of AYA cancer using SEER registry data. So again, 15 to 39 years of age, treated 1975 to 2011, a large study. What I wanted to show here, basically, without getting into the weeds too much, is simply that what I like about this paper is that it shows the big picture of mortality. In the top panel here is the cumulative incidence of mortality due to the primary cancer. So in the second are other cancers that would be chiefly second malignancies, and then the bottom are non-cancer health conditions. I think if you can try to imagine these superimposed on each other, primary cancer recurrence and death due to that for sure is the most frequent cause of death. Second cancers, less so, and down here at the bottom, which is of interest to us in survivorship, is the impact of non-cancer health conditions. So importantly, this excluded what epidemiologists call external causes like homicide, accidents, suicide, and so forth, but rather these are actually health conditions. And so it looks to me that non-cancer health conditions probably are the second greatest cause of cumulative mortality, even over second cancers in this population, but perhaps not as high as we see in children, but those comparisons haven't really been done. So future directions in survivorship, I think many opportunities for describing and characterizing late effects more completely. Certainly the need for even better surveillance guidelines. There are some available through the NCCN for AYA patients. Those are largely extrapolated from childhood cancer guidelines, and the need for more specifically informed guidelines is obvious. And then the development of innovative survivorship care models to engage these patients. In the last couple of minutes, I want to pivot to sort of what we could think of as the elephant in the room, which are the psychosocial issues of AYA patients, and something that I'm actually not able to go into too much detail on here. Most of you have probably seen this figure from the Institute of Medicine report published in 2015, but it just shows an array of challenges that we're all very familiar with that these patients encounter during this very difficult and challenging life phase, complicated by having cancer. But the resilience is remarkable as well. And these are photos of our group at Children's Hospital Los Angeles. I'm sure you could show your own photos from your center. But they do have a remarkable amount of resilience, and that's something that should be studied and leveraged further as well. This is a picture of a dynamic young woman who was treated for colorectal cancer in our adult center. She is now one of our patient advocates, actually, in our research group, and I think her defiance is shown in her facial expression kind of says it all. These are really remarkable, amazing young people. One of my colleagues, Kim Miller, had received funding from the Aflac Foundation through the COG and is conducting a study called Project CORE, which is looking at the psychosocial burden and also physical burden of late effects in a cohort of colorectal patients recruited at our institution. She's measuring health-related quality of life and medical outcomes in 18 to 39-year-olds, comparing them to 40 to 64-year-olds, sort of a middle-age group, if you will. And I wanted to share just a little bit of preliminary data that she has shared with me that is being presented at the ASCO conference, colorectal conference. So what this table shows are the means using the FACT-C. There's a cancer or a colorectal cancer specific subscale of the FACT-C, which is shown over here on the left. And as you can see, the scores range from 0 to almost 30, about 28, 24 to 28, depending on the subscale being looked at. So it measures physical well-being, social well-being, emotional well-being, and then functional well-being. That's the FACT-C, it's called. And as you can see, first of all, in this first column, this is the total sample of 235 patients that she's received reports on. Look how low these scores are. They're in the range of 14, 11 to 14 overall when aggregated. When she looked at early follow-up, in other words, between 6 to 18 months of follow-up and then 19 to 36, you begin to see some differences where with physical well-being, it's actually better farther out. So, it seems that with time, perhaps there is some recovery of physical well-being. But in terms of social well-being and some of these other constructs like emotional well-being, it is not as good, maybe even lower in the area of social well-being. So the psychosocial burden, I think we can say safely, is very significant and might change a little bit over time. What I really was interested in showing you today, and this is sort of hot off the press, is that Kim did assess the impact of the COVID-19 pandemic on this cohort of patients as part of her survey. Worked very hard to sort of build that into it in time to do this survey, and these data are really just being analyzed now. But I wanted to share this just to show this is the patients who, the respondents, almost 200 respondents who endorse these problems along here to the left. But I just, in broad picture, I was astonished to see that 40% or more of this cohort endorsed delays in cancer-related care, general healthcare, delays in obtaining prescription medications, income loss, and on down the road, increased anxiety, all things that maybe in some ways are not completely surprising, but I guess I was really taken by the large proportion of patients who have been impacted by this pandemic, something we've all felt, I think, but maybe particularly acute in certain populations. I'm going to close just by saying that I have the great fortune of working with a wonderful group of researchers in preventive medicine and other departments at USC. And I just wanted to share one of the most enjoyable things over the last couple of years has been getting the Center for Young Adult Cancer Survivorship Research going. We have 4 different research clusters focusing on biomedical outcomes, biopsychosocial and behavioral outcomes, health services, and epi and pop science. This is funded by the Southern California Clinical Translational Science Institute, and it's been a great privilege and a lot of fun to work with my colleagues in this area. So I would say, just to wrap up in the last slide, the research priorities that we might be able to distill out of this, going forward. I think there are many. Certainly more to be done in characterizing AYA cancer incidence, survival, and survivorship, tracking exactly what it means to have cancer for an AYA patient and trying to understand that more fully in all of its psychosocial dimensions, understanding more about the AYA cancer and host biology, improving cancer clinical trial participation by AYAs. What I like to refer to as upward expansion of AYA science. What I mean by that is that, as I think most of us know, a lot of AYA has been driven by pediatrics, and that really needs to change. And we need more collaboration between pediatric and medical oncology, both at the practice level and the research level. There's more of that going on now, more than ever before. Again, topic for another lecture would be the wonderful work that is happening between the adult groups in the NCTN and COG with developing new trials like the current Hodgkin and germ cell trials, which are truly collaborative efforts, really exciting and really needed, and I think the way of the future. Many more people here than I can acknowledge appropriately and properly, but lots and lots of people have contributed to the work that I've shown here today. And with that, with about a minute to go, I think I'm going to go ahead and end, and thank you very, very much for your time this morning.
Thank you. I'm trying to pull the chat up here to see if we have any questions. First of all, I'd like to say thank you, and how I am impressed I am at your ability to present so much information in such a short period of time. I think there was something there for everyone, regardless of what your interests or research or clinical interests are. And I think you've done a wonderful job of highlighting where we started as an early sort of a new field of science of AYA oncology, and where we are now and how much work we have left to do across multiple domains. So thank you so much for that. I'll give a few minutes just in case there are any additional questions people want to put in the chat, but while we're waiting on that, I am curious. My role is largely clinical, and our group focuses a lot on quality improvement initiatives and things like that, and how to take some of this, amazing data that you presented and translate it clinically to support our patients better. From some of the data you presented today, has your institution had any really successful projects that they have implemented as a result of the science?
And you're probably asking with regard to bridging the pediatric and adult divide. Yeah,
that'd be a great example.
It remains a challenge, Dr. Sanford. I'm not entirely certain of the fine points of your geography here, but in Los Angeles, we are not on the same campus as the adult facility. We're about not that far, 4 miles or so, but it could be 30. You just don't run into your colleagues the same way that you do if you're close by. I think there's nothing like personal relationships to build these kinds of systems, whether it's research or clinical care. Knowing the people, having relationships with them has been, really vital. It has gotten better over time at our hospital. I work at both the Children's Hospital and the Adult Cancer Center, taking care of cancer survivors, and I co-direct the AYA program in partnership with one of the medical oncologists. So that's given me the opportunity to really develop personal relationships with a lot of the medical oncologists. And I think we're gradually making headway in things like, joint tumor boards and sharing patients and trying to develop ways to transfer patients, back and forth between the facilities. But it's very, very challenging. Lots of insurance challenges, even within the same sort of academic system. The institutions, contract separately with insurance companies. And so, it's not as uniform as it could be. We're all on Cerner. But none of the Cerner systems actually interface with each other. So, that there are additional layers of challenge. So I think the commitment is there, the desire is there. There's a lot of goodwill on the part of both medical and pediatric oncology to make this happen. But I think we have to try to align some of the structures, to support our work a little bit better.
We're actually pretty close geography-wise these days, but you're right, the infrastructure, and we're about to get into the weeds of some of those other things. But
I wish
Thank you. We needed all that.
Good luck with that. Yeah.
We do have a clinical navigation program for our AYA, and a navigator and a coordinator who crosses both bridges, which has been great.
Nice.
It's a great addition in helping us build those bridges.
Yeah, I think navigators can be extremely helpful, for this type of a thing.
Yeah. Well, I could talk to you probably all day with all my questions, but if there are any other questions from the rest of the attendees, I suppose we can wrap it up today. I'm going to be processing and reviewing your slides for sure.
Sure. Yeah, I know that I ran up right to the hour. I maybe was a little too ambitious in the information. This is my passion, and so I like to share it all. So I apologize if we ran out of time on my account. But if anybody is interested in reaching out to speak with me directly, please don't hesitate. I'm in the COG directory, and Dr. Sanford and others have my email address as well. So
thank you.
I really want to thank you again for the opportunity.
Yeah, and hopefully we can have you back in person sometime soon.
I'd like that.
Happy holidays, everybody, and have a great weekend.
Happy holidays. Bye-bye.
Thank you.